All right, welcome to the McLean Hospital Crafting Support Project 2025 Family Webinar Series. I'm Dr. Julie McCarthy, and I'm a clinical psychologist and researcher at McLean Hospital. Tonight, I am very excited to have you with us for a presentation on tools to enhance the family member experience in psychosis care, such an important topic, with Dr. Oladunni Oluwoye from Washington State University. Before we begin, I'll just go over a few reminders. Folks are welcome to change their names for privacy purposes or make any questions or comments anonymous. And please enter any questions that you would like answered in the Q&A box, and we'll save plenty of time for that toward the latter half of the presentation. And then we ask that you do use the polls and chat for our audience participation when appropriate, and to share any comments, resources that you might like. And I'll be recording the presentation and Q&A discussion, and when recordings are available, we'll let attendees know. To continue to improve this webinar series, because it really is meant to be useful to all of you, we encourage you to complete a brief, anonymous, and voluntary feedback survey to share your thoughts, preferences, and ideas for future webinars if you have any. And this information really helps us for quality improvement purposes, and may be shared anonymously in the future with researchers or folks like us interested in expanding support for family services. So I'll put that in the chat now for anyone who needs to run early. Okay, so first up, we'll go over a little introduction to the webinar series for anyone who might be new, then we'll dive right into the presentation and then move to Q&A and closing remarks. So we're here as part of the Crafting Support Project, and to see who's here with us, I'm going to start the poll of who we have in terms of your role, in terms of what brings you to the webinar tonight. So let me bring that up for you all. Okay, so what best describes your role? It could be family member, person with lived experience with mental health challenges, clinician, none of the above, or intersecting identities as well. So if you don't mind, feel free to pop that into the poll, and then we'll see a summary of who's here in just a moment. So we'll close the poll in 3, 2, and 1. Okay, so we have the majority of people with us, 81% family members, and then about 19% clinicians. So thanks so much for coming. Okay. And why we even have this webinar series is because at some point or another, we may have found ourselves in a situation where we wanted to help a loved one, and we may not have known exactly what to do. And so over the years of putting this philanthropy-funded project together, we've been able to collect a series of evidence-based tools and resources to share with all of you. So we don't have to wonder what to do. We can really think about what the options are out there and get started thinking about what we can do as family members or as clinicians, helping clients and family members navigate their mental health recovery. So this year we've had a wonderful lineup of presentations. So we're in our second to last one tonight. We have one more in November. And for those of you who are looking for past webinars, feel free to check out our Crafting Support Project YouTube channel, and we'll have more from this year uploaded soon. And we also have, as the other part of the outgrowth of the Crafting Support Project, our Crafting Family Support Program, which is a new program just for Massachusetts families. And we offer 8 weeks up to 12 weeks if needed of weekly one-on-one sessions with a coach or therapist like myself. This could be in Zoom or in person, and we just started this summer and will be ongoing for the foreseeable future. And this is for folks who are unable to get coaching or this type of one-on-one support otherwise in research studies or other opportunities at our hospital. So if folks are interested, feel free to get in touch with me at jmccarthy@mclean.harvard.edu, and this is insurance-based. All right, so before we move into our presentation for today, I'd love to hear in the chat briefly, what is one of the most helpful mental health resources that you would recommend to families who might be going through something similar to yourself, or maybe something that you've just personally found helpful, so that we can kind of hear, where people are already finding some of the tools that might have been helpful to you so far. So feel free to put that in the chat, and I can share with the group, since the panelists will be able to see the responses, but not necessarily the attendees. And if you're not sure, We also have resources that we will certainly hear about in our presentation today and that we can also share after our presentation as well. To get us started, some of the resources that I've heard from families in the past have been things like NAMI Family to Family, the National Alliance on Mental Illness Family Supports, or different hospital-based support groups, things led by families or peers who have gone through similar experiences. And also people have found helpful sometimes things like the Schizophrenia and Psychosis Action Alliance, which is a nonprofit that's offers support groups, resources, toolkits for people as well. So if you have any ideas that you'd care to share, feel free to put them in the chat. All right. And so in just a moment, we will hear from our presenter. And Dr. Oladunni Oluwoye is an associate professor in the Department of Community and Behavioral Health at Washington State University, Elson S. Floyd College of Medicine. She also co-leads the Approaches to Community Mental Health Collab. She is also a faculty member of the PRISM Collaborative, where her research focuses on increasing racial health equity in mental health care. Dr. Oluwoye specializes in improving access to and delivery of treatment in community-based settings, with a focus on ethno-racial minoritized families navigating early psychosis and coordinated specialty care. So please join me in welcoming Dr. Oluwoye. Go ahead and take it away.
Thank you, Julie. I'm really excited to kind of be here and be talking about family member experiences and some of the tools that I am a big proponent of and suggestions that I provide to other people. I think that I've had the opportunity to kind of go back and look at some of the different webinars that have kind of come through, and I'm just really impressed by the ability to have these webinars and really engage family members and individuals with lived experience in these opportunities. So much so that I am going to try to bring it back to Washington State and shed some light on what's been going on in some of the other states that I think is beneficial and impactful. So I'm going to start with my presentation. We can save questions to the end or at any point if you want to ask questions, that's totally okay with me as well. Okay. So here's my disclosures. I don't have any financial interests or conflicts to report. I do list down some of the funding that I've received. A large portion of it has come from the National Institute of Mental Health and from Washington State Healthcare Authority as I lead the evaluation and training of clinicians in measurement-based care here in Washington State and our early intervention programs. So I like to kind of start these presentations off, really given a description. It says about me, but it's really just my positionality and how I kind of entered this space and the work that kind of informs different parts about myself and my own experiences that kind of inform the work it is that I do. So I was trained as a mental health counselor from a historically Black university. And so that kind of led my segue into really thinking about substance use, because in an earlier life, I was all about focusing on disparities in substance use, especially among college-age students. I am a researcher. Julie had mentioned I am an associate professor in the College of Medicine here at Washington State University. And so I do a lot of qualitative and quantitative work, but really focused on people's experiences and pathways to care before they even get to early intervention services. The next part is I'm an immigrant. I'm a naturalized citizen, but I moved here from Australia when I was about 17 years old. And kind of engaged in the whole immigration system, just relocating here and just doing that also as a Black Nigerian and historically just my culture. And then last but not least is I'm a mom, I am a daughter, and I'm a wife. And through that, I have an extended family and just historically and culturally, I also have a lot of family that's still based in Nigeria and in Australia. And it's through those different experiences that I have family member experiences in just terms of interactions with the criminal legal system, family experiences of family members and siblings with substance use, and engaging in substance use, and just also experiences as a sibling and as a family member of individuals with serious mental illness, and primarily schizophrenia and bipolar disorder. And so I really kind of use all of these different experiences along my life and through my journey to really inform how I enter the space of early psychosis and why I am specifically emphasize or really care about family engagement in services, but also the experiences of historically minoritized individuals, which is really at the center of a lot of the work that I do. So I feel like I'm kind of preaching to the choir here, and that there's been a lot of different webinars that came earlier this year and even in previous years that have really talked about the importance of family members, and not just family members, but other support individuals. For a lot of individuals, family members may not be around, but in combination, they play a key role on the pathway to care and are vital for clients throughout care, especially in terms of engagement, getting access to services, their pathways through early intervention services, and just navigating different systems that may not just be focused on mental health, navigating employment benefits, navigating educational systems. Family members and support persons play a key role just in a magnitude of different ways that's really linked to just different outcomes that we see over time. So here's some of the ways I've just bullet pointed it down, where family members have an impact in being primarily responsible for the initiation of treatment and first hospitalization. Interactions with family members play a key role in terms of connecting with inpatient staff, which is associated with the initiation of outpatient services. Family contact is also associated with better work performance. Living without a family member is linked to disengagement in coordinated specialty care services, so early intervention services. And family member support person engagement increases service user engagement throughout care. Some of these bullet points that I'm kind of running through really give an insight into the different components that are embedded and why it's really important to have that family education and support component embedded within coordinated specialty care programs. And so it kind of predates CSC is what we really call it, with focusing on literature that has demonstrated engaging families and family member engagement in services, especially for individuals on the schizophrenia spectrum, has an impact in these different outcomes that we see over time. And that really gave the premise for why we have this core component embedded within early intervention services. The 2 points at the very end of this slide, so living without a family member is linked to disengagement, and when family members are engaged at various points in early intervention services, it's connected with a longer sustained continuous engagement from service users. Those 2 points are really coming from work that has been done, especially within coordinated specialty care. So more recently, really thinking about how that family engagement is beneficial and how it kind of serves as a little bit of a protective factor in terms of service utilization and engagement in services. And so I just wanted to kind of give some of that context as we kind of move through, especially the last point, which I'll kind of flesh out a little bit more. So when I think about initial engagement in coordinated specialty care, especially from the family member side, attendance and engagement in that first appointment is very vital. It's very much linked to continuous engagement in services, but I really view initial engagement and whether family members choose to engage in that process really based on their experiences on the pathway to care. I think for many individuals, that pathway to care can be very tenuous. It can be very traumatic for individuals, which will then impact whether or not individuals are engaged in coordinated specialty care when and if they get to coordinated specialty care, which we know is like the gold standard of early intervention services for psychosis. And so what we see within coordinated specialty care from many different programs in various states is that less than 50% of individuals are attending that first appointment. And that less than 50% of individuals also then matriculates through engagement and what that engagement rate is as individuals move throughout services. So essentially, if we're not engaging individuals and family members in that initial appointment, it is less likely that we're actually able to engage them later on. And so that then has an impact on service user engagement. I put this slide on here to really kind of depict how important that initial engagement part is and what we kind of think about in terms of how do clinicians then engage individuals, especially if they've had negative experiences prior to getting into early intervention services. And what we can think about in terms of how family members can kind of improve or enhance those experiences and coming into that space as this is a new experience that is vastly different than potentially some of these other experiences or other systems of care that individuals have engaged with prior to get into early intervention services. As I had kind of mentioned, initial engagement is also then linked to continuous engagement. So if we aren't engaging family members, you all in services within the first 3 months of coordinated specialty care, it's less likely that we're able to then re-engage you, even as a loved one is moving through care. And we also know that if we're able to gauge family members in the first 3 months, we see a more sustained engagement for clients in services. So for every month family members are engaged, it actually increases the ability for clients to then engage in services for a longer period of time. So really thinking about premature disengagement. And that's easy, right? Like, sure, we can absolutely do that. And research is research. And a lot of what I had just mentioned is really just based and really based on data that we've collected here in Washington State, as well as just different research studies that have kind of depicted how we should be thinking about improving family engagement in services just because of the vital role family members play in those services. So now I'm going to kind of move into tools that I think help facilitate engagement, tools that have some evidence to support it as well, and how we can think about adapting some tools that weren't necessarily created for family members, but that have been impactful for service users, and how we can kind of think about that and integrate that into different experiences. So one thing that I like to kind of throw out there as a level set is really thinking about your own identity and your own background. I gave a little bit about my positionality at the very beginning and different things that kind of make up the whole of me that are vitally important. Those things shape the care individuals receive or the care that I would receive, my engagement or hesitancy engaging in different services, and then how I come into those spaces and think about those clinical interactions. And so I want you to really think about how different ways your identity or your background shapes your perceptions, shapes how you engage or disengage from certain spaces, shapes how you think about protective things that you put up in place, right, in order to protect you from certain experiences that maybe make you feel uncomfortable. And then really think about how your identity and background leads you into these clinical encounters with not only your early intervention program clinicians, but just with other systems of care as well. That same identity may be shared with your loved one that is engaged in services, but they may then also craft their own identity and background, right? And so there's maybe some overlap with family members in some of those shared identities and backgrounds, and there also may be a little bit of a departure in that as we think about as generations kind of build and grow on. And so every family lives by a different set of systems, knowledge, concept, rules, and practices, right, which also change over time. And this really is the running definition of culture. I didn't put culture on here because a lot of the times when I speak to different families who may not be ethno-racially diverse, the first thing that comes up is, I don't have a culture. And I'm here to say that everyone has a culture. It's just not thought about in the same way that we may have been sensitized to kind of think about it, where it's really just based on someone's ethno-racial identity. Where you grew up forms your culture. The different experiences within your home forms your culture. And so I've kind of listed some of those bullet points down here, such as customs, language, religion, spirituality, family structure. All of those things make up a particular culture that you may identify with or have crafted for yourself. So one of those tools is the cultural formulation interview. This tool was a tool that was specifically developed for clinicians to use in care. It's a tool that has open-ended questions. If you actually gave it a quick Google, it would come up with a wide list of different versions and different images to kind of conceptualize these different elements that make up the cultural formulation interview. Clinicians are trained to utilize this in an open-ended manner to really have different conversations, to really have a good understanding about one's identities, how they conceptualize and think about psychosis. It's not developed specifically for psychosis, but how one conceptualizes their own experiences, how one thinks about psychosis, what the causes are, different stresses and supports that individuals have, the role of cultural identity. And it really is a nice way for clinicians to engage in a conversation as a bit of a stepping stool to kind of open up those different conversations, to get a better understanding about individuals' experiences with psychosis. And so, as I had mentioned, this tool was originally created for clinicians with service users, right? There is a wide variety of different literature that supports the use of this tool in helping build rapport, informing treatment planning, helping to improve diagnostic clarity on clinicians, on the clinician end, but it also has a positive impact on medical education. And so there's evidence to really support clinicians utilizing this tool within care, and not just at one time point, but then utilizing that information over time, right? Always coming back and making it very person-centered, integrated throughout treatment. The one caveat for this is this tool wasn't intended for family members. It wasn't created for family members to use in order to build engagement in the same way that we think about all of these positive outcomes that are related to the use of this tool by clinicians. It rarely has been used with family members as a way to improve engagement, as a way to improve medical communication with family members, as a way to really think about the household or the larger structure that then surrounds an individual and what supports are there. I think one part that I didn't necessarily talk about is that early intervention services, yes, are created for service users, but they can also be a support for family members as well, in terms of helping to improve communication with their loved one, but also as a way to actually just help solely the family member work through different things, get connected to other services. And so that's kind of how I think about the cultural formulation interview. And I'll also go ahead and start to talk about in a little bit how we've then modified the cultural formulation interview specifically to use for family members. So one thing that I want to kind of share is there's more than 4 questions in the cultural formulation interview. I would say it's like quadrupled the amount of questions that I'm showing here for each of these different overarching categories. But these are questions that I think that you can ask yourself in a way that hopefully there are also ways that you can also then share them with your early intervention team that supports your loved one, right? So how would you describe your experiences with your loved one is one of the questions that comes out of the cultural formulation interview. Are there any kinds of supports that make your experience better or worse? And so really thinking about you as a person, not necessarily you in your role as a potential caregiver. What types of help are most helpful for you and what things are not helpful for you? Current help seeking practices. What kind of help do you think is most useful to support you at this time? And so if you think about these questions and how you would answer them, these are the same things that you can potentially share with your clinician, right? Your family education and your support person, especially within a coordinated specialty care program or other services. It's a good way to kind of start those conversations that may lead into something else that then provides the clinician more context and the ability to kind of build on some of these starting points. Additional considerations that I always want to mention is, what if my loved one enrolled in care does not want me to be involved in their care? That is like a running question, and that happens more times than not, where the individual enrolled in services doesn't necessarily want their family member enrolled in care, but the family member wants to engage in services. And for a lot of teams, there is a hard line with that. If the individual enrolled in services does not want a family member to participate, then the family member does not participate. But one thing that you can think about is just the introduction of multiple options. Maybe this is a conversation that you can still broker with the clinician in terms of, okay, is it an absolute no, which is fine, right? That's an absolute no. Or are there different conditions that can be met? And I put this up here because it's not something that has not been used. This has been implemented in a lot of On-Track New York programs and having various levels of involvement. So it isn't just a yes or a no. A lot of the times with our programs here in Washington State, this is the same thing that I say to the programs is, you can have various levels of involvement that can still be set by the service user or the client enrolled in services, where you're then still respecting their boundaries. But family members are also still able to get certain things out of the family education and support component. So one example for that is involvement with conditions set by the client. And the example that I provide here is, yes, I would want my loved one to participate in family education and support, but I do not want to be involved in family education and support. And I do not want you sharing any information about how I'm doing in services with my family member. This then allows family members to get the needed information or skills that they can learn from that family education and support component, while still also respecting clients' boundaries of, I don't want my information shared with my family member. And if a team isn't necessarily doing, this is something that you could potentially ask, is this an option? And kind of go from there. But I will say that there is some literature to support this method that you could probably also go back and rely on, and that's from On-Track New York. So I'm going to kind of share with you now just a little bit about the work that I've been doing in Washington State that kind of puts some of these different pieces together and the impact that it's had on family members through a pilot study we did. So in Washington State, our New Journeys program, our coordinated specialty care program is called New Journeys. And there are 16 programs throughout the state. And so I partnered with 5 of those programs to kind of pilot test the family motivational engagement strategy, which we call FAMES for short. So, so FAMES includes a modified version of the cultural formulation interview that is really being tailored in a way that alters some of those questions to be very much focused on family members. So when we ask these questions, it's like, well, who supports you in your home? Where do you reach out to? Who do you talk to? Could it be a religious leader that we could then engage with you on, right? What things have you not liked that you've participated in? Excuse me. And so part of FAMES is it provides brief weekly contact that is then in addition to the family education and support component embedded within coordinated specialty care. And it's loose contact that is very flexible, that is very much based on people's preferences. Because while sometimes we in mental health services really mark engagement as, did somebody attend an appointment? Engagement can actually mean something a little bit more broad than that. I'm able to actually contact a lot more people over the phone, but I can't necessarily mark that as attendance of services because it was a brief contact over the phone. And what we know is that there's a lot of barriers to family members engaging. There's work-related activities. There's other family members within the home that have different activities going on at the same time. And so a big part of FAMES is the ability to be really flexible by engaging individuals in non-traditional hours. So not just thinking about that 8 to 5. That can often be a barrier. And different ways people communicate. I don't know if anyone is like this, but a lot of the times I just lay in bed and I'm emailing on my phone, right? Like I'm doing those responses. It ends up being one of those activities where I'm like, I can just do this when everyone is put to bed and sleeping, and these are things that I can just respond back to. Same thing with text messaging. These are things that people can do on their break as they're taking a walk in the evening. That doesn't necessarily mean that they have to physically go somewhere to attend a particular appointment. FAMES is also really focused on the first 3 months of services, because we know that if we are able to capture individuals within those first 3 months, then we have more continuous engagement over time. So how we've kind of used the modified CFI within this is really thinking about the role of identity, like what are the most important aspects to someone's background that make their experiences different as well. And so we really try to get a good understanding about how individuals define and think about their own identity and their own culture. And sometimes it takes a little bit of time as we then start to ask more questions, especially if we get the response of, well, I don't have a culture. I don't have any specific traditions or customs that are unique to me. Sometimes we just flesh that out a little bit more. And then we find the things that are most important to them, making sure that we always circle back to that, making sure that we are not providing suggestions that don't fall into the things that are identified as the most important aspects. Another part of that building phase is really thinking about traditions that influence how they approach helping their loved one, and things that they would want, how they would want to be approached. And so if one of those things is, no, I go to church, in Black Southern churches, oftentimes there's like a health core group, right? I like to engage in those services, and so I connect often with them. These are things that we then think about, well, hey, if this is stressful, if you're in a stressful time, how about circling back to where you find a space where you find that is least stressful? And then we take some of all of this information and we share it back with the clinician, right? Because we're like a insider, outsider, outsider, insider in this role. The whole premise of it is to not come at it from a very clinical aspect, but coming at it from a very supportive way, really thinking about building connectedness that oftentimes people may not get from their clinical team. And so we're able to kind of get some of this information, share it back with a clinician who then immediately can send resources back to the family member. In Washington State, those family appointments are once a month. And so this serves as a nice interim because it allows individuals to have that contact in lieu of some of these monthly appointments with a clinician, and still have that communication with a clinician who's then sending helpful resources to an individual by email or by text message without the need to attend things in person. So we piloted this study with 38 individuals. Most individuals actually preferred speaking on the phone. And these phone calls really ranged from 15 minutes to 40 minutes, and sometimes served as just a way for family members to just talk about their day, things that were stressful, things where they felt like they got support from, or places where they felt like they weren't able to get support from. And it just became a really good way for them to build connectedness while also alleviating some levels of anxiety and stress that they were encountering on the day-to-day basis. 87 appointments were attended, and that is still also including individuals that responded immediately by text or responded by email. And then we were able to kind of engage individuals within the first 2 months of services. That then had an impact on their that then had an impact on their engagement in the family education and support services. And I really think about FAMES as providing the extra nudge that individuals need to attend those family education and support services, because they've now been then created or modified or informed in a way that aligns more with family members' needs. So I'm going to kind of leave you, I have 2 more slides left, but leave you with 2 things. Building partnerships with what I call ease. One thing is thinking about the ability to express your needs to clinicians, to a team, whether those needs are, I need services for myself, whether those needs are, I need to figure out and learn different skills in order to better communicate with my loved one. It could also be like, hey, I'm struggling to address substance use with my loved one. The ability to express your needs to a clinical team allows them to then think about that in different ways, right? So knowing that you can always express your needs with different members of the clinical team. The second part is ask. Ask for what is available at that agency that you're connected to, and ask for what's available in the community. Oftentimes, clinicians and teams actually know about a lot of different resources within the immediate community and more national resources as well that you can then potentially engage with and build some support out of. The third part is support. Allow clinicians and teams to show up for you. I think I am a big proponent of coordinated specialty care in terms of really thinking about it is a mental health services that is really comprehensive, that shows up for not just individuals enrolled within the program, but also for family members. I've heard from so many different family members, and it's so great that I'm able to then share that back with the teams, that oftentimes they just think of them as an extension of their family because they just regularly show up in ways that counteracts maybe some of the poor experiences they had before getting to that place. And so allow clinicians to kind of show up for you. And their ability to show up for you is, one, based on your ability to express your needs with them, to create in a safe space, but also letting them know about you're looking for resources. So what is available? And if those resources are not available, it is still a good way and it's still a good point to then still share that, like, this is a need that it is that you want. Oftentimes, if enough people share the same need, new things can be developed, right, to address those different needs. And the last one is engage. Stay connected to your loved one. Think about open communication. Stay engaged and connected to your loved one's services and their providers. And it's not to say that you're going to have the most budding relationship with every provider on your loved one's team. That's probably just not going to happen. But the hope is that you're able to find someone to connect with, that you can stay engaged with. And this is irregardless of whether or not your loved one wants you involved in their services or not. I think that having that open door of, at any point in time, if my loved one changes my mind, I am there. I am engaged in services. I will attend appointments. I will do all of those things. And I think that that is equally important, because the whole talk is about engaging in services and that impact on service outcomes. And so here are some just additional resources. I really did spend some time looking at previous webinars, and they were really good. So one of the things that's come up multiple different times is Milo, motivational interviewing for loved ones. I think this is just a really good approach that really just thinks about the skills that loved ones can get, and how they can then apply them within their own family context. I think it's a very unique and novel way of thinking about motivational interviewing, in the non-clinical sense that we think about, oh, this is only what clinicians can kind of deliver. And so it's really thinking about what skills can be developed and transferred, so individuals can kind of use that on the regular basis. Schizophrenia and Psychosis Action Alliance is a nonprofit organization. It has a national presence. They have some really good resources on their website as well, such as a caregiver toolkit, different stories, and they also have a seminar series as well. The other part is Coping with Schizophrenia, Psychosis and Schizophrenia. And this is a picture of the book. I was gifted this book, and it's a really good read. In terms of really thinking about, sometimes it can feel like you're on an island, And it's really nice to kind of read different stories from a wide variety of family members. We often just focus on parents within that caregiving role, but there's a lot of siblings that are also caregivers. There's also a lot of partners that are a lot of caregivers, and that they're the primary family members. And so this is a good book that kind of shares those different stories from different family-based roles. And so if you're looking for a good read in terms of thinking about stories of hope and recovery from a sibling point of view, parents, grandparents, partners point of view, I would say really think about reaching and getting a copy of this book. And so I'm gonna leave it at that.
Thank you so much for such a wonderful presentation and so incredibly thoughtful, kind of the process with which you developed your ideas, really listening to families, and ultimately creating a tool that sounds so valuable because I think so many of us know the importance of family involvement in theory and also in real life practice. Sometimes it can feel hard to do, maybe for folks who are less familiar with that or don't exactly know what to do or say. And so I really like how you distilled down some of the questions that any of us could ask ourselves and think about our role as family members and also as clinicians, how we can meet people where they're at in very different approachable ways so that involvement doesn't necessarily mean sitting in front of a chair in front of you, dealing with traffic, dealing with parking, to make that happen. So anyway, we're going to turn things over to our Q&A. And thanks for the folks who put in the Q&A that unfortunately chat was disabled earlier, so apologies there. Couple of resources that our attendees had also shared was DMH, or at least in Massachusetts, that refers to the Department of Mental Health. And then someone else shared a book by Dr. Jeffrey Lieberman, Malady of the Mind, Schizophrenia and the Path to Prevention. So one of the questions that a family member had raised is something difficult to deal with, which can involve physical changes that a loved one might be going through. So that is often due to medication, could be due to other things though, and sometimes that can be challenging. And depending on what people's physical health concerns might be, sometimes this could involve side effects of gaining weight or other associated concerns. And so I guess in terms of how families can play a supportive role in certainly wanting to encourage people to continue taking medication if that is indeed helpful for their recovery, how can families perhaps broach conversations about other physical health concerns that may also be tied to medications that are supposed to help in different ways?
I think that is a really good question, and I think that a lot of people ask, right? I think one part of it is like, okay, I see the benefit of medications that my loved one is on, right? So that my son is on. But there's also then these side effects that may be attributed to that medication. And so I would say this in terms of writing what those changes are, right? And kind of making like your own diary of these are the changes that I have noticed over time. And if you're involved in your loved one's care, then sharing those concerns. Part of what I think then is also is whether or not your son, right, your loved one, shares those same concerns. So having a conversation, like, because sometimes like as parents, we notice things that don't actually bother our kids, like at all. It just becomes a major concern for us. So I think having that conversation with your loved one, like, hey, these are some changes that I have noticed. Are these causing any type of distress for you? Are you concerned about any of these changes?
Right.
If there's agreement there, then I think then you take that information back to the team. Like here, we both have concerns about the potential impact. Are these actual side effects from this medication that my loved one is on, or other things potentially going on? And I would do that, right? I think we think about how things may be a little bit different in early intervention programs, but think about how things are in like primary care, like the things that they tell us in primary care. Document your symptoms. How long have they been occurring for? Come back. And I'm really much under the presence of, I don't care if my doctor gets annoyed that I pull out a pen and a paper and I'm writing all of these things down. What I care about is I'm able to provide you with very specific details that you're then able to use your knowledge and your expertise to help me comb through these. It really goes back to you are the expert in yourself. And you're sharing that expertise and your experiences with other people so they can then better inform the level of treatment that they're providing.
Great. Thank you so much. That sounds really useful so that we can focus on what family members can do and also how they can use some of this data that they might be collecting, to talk with their loved one and also their clinicians too. So one of the questions that I wanted to bring up was, to what extent are siblings perhaps addressed in some of the mental health supports that you had mentioned for families, like in FAMES? Is this just a certain type of role in the family predominantly, or how much are siblings involved if they want to be? What does that look like?
Yeah, so with FAMES, any family member.
Okay.
It is really under the premise that different people take on different roles, and different people end up being the support person, even if there's other primary caregivers within the home. I think when we think about early intervention services and coordinated specialty care, I think there's less of an emphasis on siblings.
Sure.
And I think that that's an area that I've been having more conversations about, just the impact of having a sibling that has experienced psychosis, how family dynamics may shift and change, and where siblings then fit within that, within that new constructed space. And so I would say that there are many programs that do multifamily group. Those multifamily groups can include then working with siblings if they want to participate. And I think part of it is if there is an impact, and this goes back to like expressing like needs. If you are a primary caregiver and you're engaging with the family education and support person within your program, you can talk about things that aren't directly related to your loved one enrolled in those services, right? And so having a conversation about like, I have another kiddo, and I feel like there's an impact on my child, right? Or there's communication things and different shifts happening, or how do I actually even navigate different time, things that are taking up different time. I think talking through that with somebody will allow you to then think about, well, what are the different options, and having somebody else come in and ask you and provide what those different options could potentially be, especially for other siblings in the home.
That makes sense. Thank you. And so a question that often comes up, and we love to hear different people's perspectives on this, is what recommendations do you have for family members who may be wondering how to encourage their loved one to try a new treatment, whether it's getting into a coordinated specialty care program at all or a new component of treatment? For instance, if someone is up for taking that medication but hasn't done therapy, or if they love their therapist but they don't want to try medication, but maybe both are being recommended, what strategies do you feel like have been helpful for the family members that you've worked with to have some of those discussions?
Yeah, I think one of the biggest things is really just identifying what the hesitancy is. And really being open to what that hesitancy is. I think it also then goes back to just generally how kids are, which is when they feel a little bit of pressure from parents, there can be like a shutdown. Right? Like, or they feel like a question is a little bit loaded because they're already kind of thinking like, oh, my parent wants me to answer like in a particular way, right? Like they already feel that.
Yeah. They're pretty smart.
They're pretty good at that.
Yeah.
Is really just coming at it from just this is an open communication. This is really just to gauge, would you be interested? If there's hesitancy, then kind of navigating what that hesitancy is. What I've also found helps kind of bridge that is having their kiddo or their loved one connect with other kids. To know that, no, it's actually totally fine to go this route. it's more of a, we talk about peer pressure, like this is like peer support. In that sense where if they see other people doing it, they're more likely to kind of engage in that.
Mhm.
And that there's various levels of engagement. Maybe it's just like, well, let's try it, right? We don't have to like
Mhm.
enroll in all of it, but let's do like a soft launch. Let's do a warm-up period.
Mhm.
And working with whatever component or whatever agency or services that's being
Mhm.
provided to like, hey, there's some hesitancy here. So we need to do a warm-up phase where they don't feel overwhelmed by all of it coming at them at once, but they
Mhm.
get a little bit of um, an initiation into some of the something new.
Yeah, yeah, definitely. Thank you. And I wonder what thoughts you have about the important point that you brought up about different levels of family involvement and whatnot. How have you managed things if you've run into situations where a service user might be okay with, let's say, one family member or parent being involved and talking to them and not the other, for instance, and they may
Hmm.
be all living under the same roof or part of the same family?
Yeah, I think it's really leaning on what their preferences are.
Mm,
Um,
mhm.
I haven't really run into like a service user saying, I want one family member involved and not the other. It's
Okay,
usually like the the caregiver that is like, I'm the one involved and not the
I
other.
see. Yep.
Um, and it's usually, I think the other way from service users and clients enrolled in the program, it's more like, I don't want my family members involved at all.
I see.
Um, and sometimes there's reasonings behind that. Sometimes, actually, all of the time, there's reasonings behind it.
Yeah.
Some of those reasonings just may be um, just a non-supportive family unit, right?
Mm, mhm,
And so kind of fleshing some of that out more is really important. Other times it also could just be a level of independence that someone is trying to exert. No, this is for
mhm,
me and it's just for me. And this is something that I want to kind of engage with on my own.
mhm.
And so that's really more of what I've encountered, not necessarily like one person saying, I want one person and then not the other participating.
That makes sense. Thanks so much. All right. So, um, what about a scenario where maybe someone's been in treatment? They've been there, kind of done that. One family member kind of brings up an adult child who has had some services, but maybe not necessarily consistently. And so, what approaches do you feel like might be helpful for someone who might not feel like they need additional services? Like maybe they feel like, okay, they've got it, they've learned what they came to learn, and they're moving on. Whereas the family member might feel like ongoing support could actually be really beneficial. And maybe even those clinicians that they've worked with may feel similarly. Um, any thoughts on that, especially when there could be differences like this, and also with someone who's certainly an adult, they have the freedom to choose what they want to do, typically outside of legal mandates to
Yeah.
do treatment.
Some caveats there. I think this is where step down becomes really important.
Mm.
Um,
Mhm.
and it's not, step down is not the same, and it's not universal for all coordinated specialty care programs. Um, and I think that as a family member, if you have those concerns, I think you can talk with, this is where it just goes, you can talk with the team and
Mm.
think
Mhm.
about what does that step down look like. So here in Washington State, there's different markers that need to be met in order for an individual to graduate.
Mm.
And so
Mhm.
one of those things is, did they reach the goal that they set out to, whether it's an educational goal or an employment goal? Do they have stable symptoms? Because we do a lot of measurement-based care. Do they have stable systems for the 3 months prior to their step
Mm.
down? Um, and have we then gotten them connected to outpatient services?
Mhm.
So these three things need to be met. And if they're met, then they go into a maintenance phase, which
Mm.
is a tapered down services for 3 months
Mm.
to see how things go if we were only meeting with you like once a month for psychotherapy, right? And if things are going great, then we move on to graduation, right? This would
Okay.
then help family members with their concerns. Like, I don't think that they're ready, right?
Right.
Well, 3 months, they did pretty good, right? And or if something happens within those 3 months, then they're not out of the program. Then they just go back to the full barrage of services as before to provide that support until they then are ready to kind of try that out again.
Mm,
These are options that I think that you can ask your program. Is there a way to step down while still being enrolled, but have a bit of a reduction in services? And let's see how it kind of goes without this,
mm,
all of the support that has been provided to us for like 2 years or so, right?
right, right.
In CSC.
That makes sense. It's sort of the bookend to the warm up period that you
Yep,
had
yep.
mentioned before. Yeah. So also, I guess thinking about even just the process that family members can go through. Somebody raised the question about dealing with grief and whatnot. That's something that I've heard a lot with different families that I've worked with as well. And so, you know, that can be difficult to accept having a loved one going through needing to get coordinated specialty care services and whatnot. And so, is there a group that you would particularly recommend? And it sounds like more of a support group, I guess, for families. And I know
So
we're on
not,
different sides of the coast.
yeah, we're on different sides of the coast. I would say things that are maybe available to you there is NAMI Family to Family has just been
Yeah.
a program that is rooted in evidence, right? And it's generally accessible wherever you are, as long as there's a NAMI there. The only caveat to that is like it's not super specific to psychosis, right? It's
True.
all
True.
inclusive. And so that's
Hmm.
one thing to kind of think about. Over at the University of UW, they do have what they call like Psychosis Reach. It's
Hmm.
a different collaborative of individuals. You actually learn a lot of different skills by being a part of Psychosis Reach. And then
Hmm.
they have different ambassadors. I think one thing that they don't often talk about is the like the group that has formed out of Psychosis Reach, the
Hmm.
connection that has formed, engaging with
Hmm.
different family members from all over, right? Because it's not just specific to Washington State.
Right.
So that could be one that I think is equally important. And above and beyond just thinking about groups, is just thinking about your need to potentially find your own therapist.
Mm. Hmm.
Um,
Hmm.
I will say that a lot of family members have higher rates than what I would expect of depression when we think about that on PHQ-9. And
Hmm.
some of that is facilitated by stress and different stresses and thinking about what that new norm is. And
Yeah.
so um, thinking about your own therapist where you can get your own support that isn't solely connected to your loved one, right? That doesn't
Right.
focus back on your loved one, but just is really focused on you as an individual.
Hmm. Hmm. Great. Well, thank you so much. I'm going to turn it over to closing remarks now because we only have a few minutes left. So in the spirit of talking about other resources, there are different groups and folks that you can talk to, at least in the McLean hospital system, that are listed here. We also have a larger resource list that includes national resources such as Psychosis Reach that you had mentioned in a PDF that we can share for the end of the webinar series as well. And for feedback, I'm going to put in the chat now the link in case you missed it earlier, because we would love to hear your thoughts. So feel free to take a moment now, if you're up for it, for sharing your feedback for tonight's webinar. We would really appreciate it. And while you might be looking at that, I just want to say thank you so much for the folks who have made a lot of this work that led to this webinar series possible, and certainly our generous donors who had made this possible with a gift to the Division of Psychotic Disorders at McLean. And then I also wanted to put a plug in for our final webinar of the year, which will be next month, Thursday, November 13th, 5 to 6:30. It's going to be a family recovery night, sharing stories of hope. And so this is a little bit different than we've done last year in that we're going to have one person who has lived experience with psychosis, and then actually multiple family members who have supported that individual to kind of get some of these different perspectives and roles in terms of what that's been like for them, because we understand that everyone's experiences is different, even if you're in the same family as well. So if you have questions, let me know, or if you know somebody else, or if you yourself might be interested in joining one of our Family Recovery Night panels as a panelist, feel free to let me know. And if you have any questions, you know where to find me. Here's my contact information. And thank you so much. And thank you again, Dr. Oluwoye, for joining us.